Hello everyone. Today we'll be revising the management of teeth with open apex, that is teeth which have some pathology and have wide open apex because they are young permanent teeth, okay, in which the root development is not complete. So, pulpal injury in teeth with developing roots. Unfortunately, traumatic injuries to the young permanent teeth are not very uncommon. They are said to affect almost 30% of the children. Okay, so majority of these incidents they occur before the root formation is complete, and that can result in pulpal inflammation or necrosis. Okay, so we need to know how to treat such cases. For this, the most important thing is that the Hertwig's epithelial root sheath, which is responsible for the formation of root, the viability of that Hertwig's epithelial root sheath is to be maintained. Okay, the root sheath of Hertwig's is usually very sensitive to trauma, but because of the degree of vascularity and cellularity in the apical region, root formation can continue even in the presence of pulpal inflammation and necrosis. Okay. So why this Hertwig's epithelial root sheath? Because it provides a source of undifferentiated cells that could give rise to further hard tissue formation. Also, it protects against the ingrowth of the periodontal ligament cells into the root canal, which would result in intracanal bone formation and arrest of the root development. And in cases where complete destruction of Hertwig's epithelial root sheath occurs, that results in cessation of normal root development. So normal root development cannot take place, but still there are certain types of cells which can cause hard tissue formation. Okay, so once the sheath has been completely damaged, there is no further differentiation of the odontoblast, but this does not mean that there is an end to deposition of the hard tissue in the apical region. Okay, hard tissue can be formed by other cells like cementoblast, which are normally present in the apical region, also by fibroblast of the dental follicle, and periodontal ligament, which undergoes differentiation after injury to become hard tissue producing cells. Okay, here we can see this is the Hertwig's epithelial root sheath. In case of damage to the root sheath, the other cells like the cementoblast, okay, which is normally present in the apical region, also the fibroblast, which are present in the dental follicle, these are the fibroblasts, okay, and the periodontal ligament cells, they can form the hard tissue. Okay, so this forms the basis of treatment of such teeth. Okay, so this is case assessment. A thorough case history has to be taken, followed by clinical examination, and all the diagnostic tests should be done to come to a proper diagnosis. Okay, I'm not going into the detail of this because this is again a very vast topic of clinical diagnosis. Okay, so vitality testing and radiographs. Just briefly, I'll tell you that vitality testing in such immature teeth is quite unreliable because they provide unpredictable response. Okay, prior to the completion of root formation, the sensory plexus of nerves, which is present in the subodontoblastic region, is not very well developed. Okay, so injury itself can also lead to erratic response. Therefore, these tests are not very reliable. Okay, and radiolucent area, here you can see the radiolucent area which surrounds the developing open apex of an immature tooth with a healthy pulp otherwise will tell us that the root formation is not complete. It is an immature young permanent tooth, okay, where root development is still taking place. Okay, so we can always compare with the periapex of the contralateral tooth if we are unable to, differentiate between a periapical pathology on a radiograph, and because it looks quite similar to periapical pathology sometimes. Okay. So open apex are always a challenge to treat in dentistry. Okay, the infected root canal space cannot be disinfected with standard root canal protocol with aggressive use of endodontic files. Okay, and once the microbial phase of the treatment is complete, filling of the root canal also becomes quite difficult because the open apex provides no barrier for stopping of the root filling material. Okay, so it can be pushed up to the periodontal tissues. Even when the challenges described here are overcome, the roots of these teeth, they are very thin and they are highly susceptible to fracture. Okay, so such teeth, they are usually a very big challenge to treat. So case selection for treatment of permanent teeth with incomplete root development. This is just a flow chart. Okay. In cases of reversible pulpitis, it's quite simple. You can do the vital pulp therapy. Okay. Teeth which have incomplete root formation. You can do pulp capping or pulpotomy depending on the case, depending on the extent of inflammation. Okay. And if it is a closed apex, then you can do a proper root canal therapy or pulp therapy. And in cases where there is irreversible pulpitis or necrotic pulp, okay, closed apex, definitely root canal therapy, and open apex, you can do either root end closure, which is nothing but apexification, or you can, or apexogenesis, and pulp regeneration, which we'll come to know later. Okay, so let's come to apexification. It is defined as a method of inducing a calcified barrier in a root with an open apex, or we can say continued apical development of an incompletely formed root in teeth with necrotic pulp. Okay, always remember that. Various materials have been suggested for the use in apexification process, but calcium hydroxide has gained widest acceptance. Okay, Kaiser was the first one to propose the use of calcium hydroxide paste in 1964, and Frank, he described the technique in 1966, which forms the basis. So in 1966, Frank, he formed the basis for apexification. He described the technique. Along with calcium hydroxide, he also presented some other materials, combinations of like camphorated monochlorophenol, etc., which are used till date. Okay. So the traditional method is the use of calcium hydroxide. Okay, formation of hard tissue barrier at the apex. It requires an environment that has mild inflammatory stimulus which initiates healing, and a bacteria-free environment to ensure that inflammation is not progressive. Okay, pure calcium hydroxide powder is mixed with either sterile saline or in an anesthetic solution to form a thick consistency, okay, like this. And the calcium hydroxide is packed against the apical soft tissue with a plugger or a thick point to initiate hard tissue formation. So the mechanism of apical closure here, just a histological picture over here. Okay, according to Michel and Schanwalker, calcium hydroxide leads to formation of a calcified material in the tissues which is not normally predisposed to calcification. So we can say it has osteoinductive potential. Okay, and Pisanti and Saike, they showed that calcium ion incorporated into the calcium barrier which is formed, they do not originate from the calcium hydroxide material which is used, but from the body's own calcium reserves. Okay, so when placed in contact with the vital tissues in pulp capping experiments, calcium hydroxide creates a necrotic layer or calcific scarring, which is called. Okay, see, calcium hydroxide has a basic pH of 12. It counteracts tissue acidity in areas where there is inflammation. It also imparts a bactericidal effect, and it fosters the formation of calcium phosphate complexes, which in turn could act as a nidus for the accumulation of calcific material. Okay. The barrier which is formed with calcium hydroxide in the course of apexification, the continued root formation is seen but rarely. Okay, for further root development to occur in the area of calcific scarring, that must not extend to the root sheath of Hertwig or to the odontoblast in the apical area. Okay, and the most common appearance of the root apex which is formed in apexification procedure is like that of a dome shaped cap. Okay, so the barrier formed with calcium hydroxide, another histologic picture, you can see dense acellular cementum like tissue is formed. Okay, and more centrally located are dense and irregular fibrocollagenous connective tissue with granular inclusions which are seen, okay, of foreign material, irregular fragments of calcification are seen. Okay, so the nature of the calcific barrier which is formed has been termed as osteodentine, which means bone-like or cementum-like material. Therefore, it's also called as osteocementum. Okay. Now, restoration of immature tooth which undergoes apexification. It has been recommended that these teeth should be strengthened by the use of an intracanal acid-etched composite resin. Okay, so apical portion of the canal is larger than the coronal portion. Okay, that's also referred to as blunderbuss canal, and the cross section of such canal is usually wider in the labiolingual or the labiopalatal direction than mesodistal. Okay, because root walls are thin. Okay, so very softened gutta-percha or obtura should be used for filling of such root canals, and too much pressure should be avoided as it can dislodge the apical dome which is formed, and the amount of heat which is used should be limited since the root walls are thin and the heat may be transmitted to the periodontal ligament with potential adverse effects. Okay. Let's know about MTA now. That is another material which is used. Okay, calcium hydroxide is widely accepted. Other than that is MTA, mineral trioxide aggregate. Okay, in 1998, US Food and Drug Administration approved this as a therapeutic endodontic material for humans. Okay, it has a superior sealing ability compared to amalgam and other materials like ZOE. Okay, so it was first developed by Torabin Ajad and members at a university in California. The composition is, it is a mixture of dicalcium silicate, tricalcium silicate, tricalcium aluminate, gypsum, tetracalcium aluminoferrite and bismuth oxide. Okay. Let's see the setting reaction. It consists of 50 to 75% calcium oxide and 15 to 25% silicon dioxide. Okay, these two components, they together comprise most of the cement. Okay, when these raw materials are blended, they produce tricalcium silicate, dicalcium silicate, tricalcium aluminate and tetracalcium aluminoferrite. Okay, on addition of water, the cement hydrates to form silicate hydrate gel which solidifies into a hard structure at a period of after say 3 to 4 hours. Okay, the MTA material has been suggested, because there is very less micro leakage compared to other traditional materials. Okay, it has been used for several pathologies like apical restorations, then furcation repair, and also in treatment of immature apices. Okay. Then let's see what is one visit apexification. It is defined as the non-surgical condensation of a biocompatible material into the apical end of the root canal. Okay, the basis is to create an apical barrier that would facilitate the root canal to be filled instantly. Okay, so one visit because we are filling the root canal instantly, single visit. Only an artificial apical stop is created and there is no effort to induce root end closure in this. Okay, so root formation is not taking place or there is not formation of any barrier, but there is just an artificial apical stop which is created. Okay. A number of materials have been proposed for this, including MTA, calcium hydroxide, freeze-dried bone, biodentin, freeze-dried dentin, all those. Okay. So in this technique, a thorough cleaning and shaping of the root canal system is done, and then MTA is introduced as an apical seal, followed by immediate placement of a suitable bonded restoration within the root canal. Okay. So though advances with MTA and bonded restoration show a better outcome, it cannot yield the result which apexification or apexogenesis can attain. Okay, maturation of the root end with better thickness of the root cannot be achieved during this procedure. Therefore, alternative approaches which allow apical maturation should always be used. Okay. See, root canal system thoroughly cleaned using intracanal instruments and sodium hypochlorite irrigation. Then to further disinfect, calcium hydroxide is placed at least for 1 week. Then calcium hydroxide paste is later rinsed from the root canal with again using 5% sodium hypochlorite and 17% EDTA, and the canal is dried. Then MTA is condensed to the apical end of the canal with an adequate plugger and or a back end of a sterilized paper point can be used, and then a 3 to 4 mm of MTA plug is left over there. Okay, and a moist cotton pellet is placed in the canal over the MTA, and then excess cavity is closed, okay, using an interim restorative material for at least 3 to 4 hours. Okay, so epixification procedure here, irrespective of the material whatever we are using, there is usually formation of an apical barrier or an apical plug. Okay, so you can see if we are putting calcium hydroxide for several weeks, then several visits are necessary. Okay, it takes at least 6 months to form the apical barrier. It is the hard tissue structure which is formed at the apex. Okay, and then against this we can fill the rest of the canal. Okay, this allows maturation of the root. The thickness of the root walls also increases with time. Then with MTA, if we are doing, at least this needs 2 visits, but can be done in a single visit, requires longer duration of, you know, uh, the visit. So it needs at least 2 visits. Here we form a plug with the MTA. This is the apical plug which is formed. So this procedure is difficult to, fill the apex compared to calcium hydroxide procedure. Here this apical plug of MTA has to set, which takes 3 to 4 hours, and then you can fill the rest of the root. Okay. So epixification, one visit epixification, in brief I have explained. Okay. Then there are certain other materials which can be used, like triple antibiotic paste. Triple antibiotic paste is nothing but a combination of metronidazole, ciprofloxacin and minocycline. And this is very effective and it has a bactericidal effect. You can see the tablets or the antibiotics are crushed into the powder form and mixed with a drop of either propylene glycol or normal saline can also be used, and then it is mixed into a paste like consistency. Okay, this is a commercially available one, pulp vase, in which ciprofloxacin, metronidazole and clindamycin is used. Okay, why clindamycin? Because minocycline has a disadvantage of causing discoloration to the tooth. Okay, the liquid is usually polyethylene glycol or propylene glycol. Okay, or if we are preparing the mixture on our own and not using any commercially available, we can mix 1:1:1 ratio of all these 3 antibiotics along with a drop of normal saline as well. Okay, the techniques which are used are normal apical barrier technique or the orthograde root canal filling. Okay, so induction of apical healing, regardless of the material which is used, it takes 3 to 4 months. Okay, and requires multiple appointments. Patient compliance with this regimen is usually poor. Okay, and temporary seal may fail, resulting in reinfection or prolongation of or failure of the treatment. Okay, so the importance of coronal seal in preventing endodontic failure is well established, and it is for this reason that the one visit epixification came into picture. Okay, then comes orthograde root filling. So in some selected cases where future non-surgical treatment is not feasible, then also in teeth with better tooth prognosis, in teeth with immature non-vital pulps and short roots, orthograde root canal filling with MTA should be considered as a valuable alternative for conventional epixification, even for one visit. So we completely fill the root canal with MTA in such cases. Now there are certain challenges, okay, for epixification procedures. One is discoloration of the tooth. So the discoloration is mainly due to the use of tetracycline or minocycline and triple antibiotic mixture. Okay, so therefore to avoid this, it has to be replaced with other equivalent antibiotics like cephalosporin, amoxicillin. A lot of research is going on. Okay. Then another one is cervical root fracture. Okay, so epixification procedures, they can leave the immature tooth fragile because already the root is having very thin walls. Okay, and it is short. So radicular walls, they are very thin, making the tooth more susceptible to fracture. The traditional use of a long-term application of calcium hydroxide can weaken the tooth. Okay, so it makes it susceptible to fracture. Then poor root development is another one. The ideal root which develops in an, that would include increase in the root length as well as wall thickness with formation of complete root apex. However, the tooth necrosis followed by regenerative endodontic treatment procedures which we are learning has reported to have an absence of increase in root length. Okay, root length does not go up to how much it should ideally go, and the root wall thickness also is not attained. Okay, then comes cytotoxicity. The intracanal medicament antibiotics, they can induce a cytotoxic effect on the dental pulp stem cells. Okay, so it can be due to the lowered pH of antibiotics because these are minocycline hydrochloride or ciprofloxacin hydrochloride which are used. Okay, so the release of hydrogen ions from the hydrochloride group of such antibiotics, they cause acidic condition, okay, which can be unfavorable condition for culturing of the cells. Therefore, the concentration of triple antibiotic in clinical usage is adjusted in such a way that it does not cause cytotoxicity on the remaining vital tissues. Okay, now let's see what is apexogenesis. The maintenance of the pulp vitality by using apexogenesis that allows continued root development along the entire root length. Depending on the extent of inflammation, pulp capping, shallow pulpotomy or conventional pulpotomy may be indicated. Dental pulp in young patients is more cellular and it is able to recover from injuries. So teeth after successful apexogenesis, they develop a normal thickness of dentine and root length. Okay, in contrast to those receiving apexification, they normally gain only an apical hard tissue bridge or barrier but not dentine because of the loss of vital pulp tissues, odontoblast, epithelial root sheath, okay, which is needed for the complete root development. Okay, so given the right condition, many tissues, they are programmed for self regeneration. Okay, and pulp tissue in immature teeth with open apices has rich blood supply and contains a structure at developing stage that is more potent to regenerate. Okay, and the general consensus for clinical treatment of immature teeth with vital pulp is to preserve the remaining vital tissue to allow continued physiological development and complete formation of the root end. Okay, so this process is called apexogenesis. Okay, here we are maintaining the vitality of the tooth. Okay. The goals of apexogenesis as stated by Weber are sustaining a viable Hertwig's epithelial root sheath, thus allowing continued development of root length for a more favorable crown to root ratio, maintaining pulpal vitality, thus allowing remaining odontoblast to lay down the dentine, okay, producing thicker roots and decreasing the chances of root fracture. Then promoting root end closure, thus creating a natural apical construction for root canal and generating a dentinal bridge at the site of the pulpotomy. So apexogenesis, it involves removal of the inflamed pulp and placement of calcium hydroxide on the remaining healthy pulp tissue. Traditionally, this has implied removal of coronal portion of the pulp. Okay, following the mechanical exposure, the pulp is left untreated. Then inflammation in one of the studies was limited to only 2 to 3 mm of the pulp. Okay, so this led to the development of the shallow pulpotomy or partial pulpotomy, which was developed by Sweck, in which only the most superficial pulp is removed. Okay, so the depth to which the tissue is removed, that is determined by clinical judgment. Only the inflamed tissue is removed, but there's always difficulty in assessing the level of inflammation. Okay. So apexogenesis, what we are doing is we are maintaining the healthy pulp tissue, the vitality of the tissue. Here we are giving the dressing and sealing the coronal portion with a restoration. So what happens gradually is that reparative bridge formation takes place, and also there is continued root formation which takes place. Okay, and the length and wall thickness of the roots also increases. Okay, so then regenerative endodontics, it is another term. Okay, regenerative endodontic procedures is a term which is used by researchers in biological based procedures designed to replace the damaged structures such as root dentin along with the cells of the pulp dentin complex. The goal is to provide a suitable environment in the root canal that will promote repopulation of the osteo or odontoprogenitor stem cells, regeneration of pulp tissue, and continued root development. Okay, and proximity to the periodontal blood supply makes the apical papilla resistant to infection and necrosis. Okay. There are three major components of tissue engineering or this regenerative endodontic procedures. Okay, one is the cell source, that is from where the cells are going to come. So odontoblasts, they are of mesenchymal origin. Under appropriate conditions, these cells, they form the dental pulp, the apical papilla, and possibly other tissues which are which can form odontoblast like cells. Okay, so to date the precise cell source which supports continued root development is unknown. Okay, the second most important component is the physical scaffold. Okay, so tissues are three-dimensional structures and appropriate scaffold is required to promote cell growth and differentiation. Extracellular matrix molecules, they control the differentiation of stem cells. An appropriate scaffold might selectively bind and localize the cells. It contains growth factors and undergoes biodegradation over time. So a scaffold is far more than a lattice to contain cells. It has growth factors. So one of the most important scaffold which has been suggested is the platelet rich plasma. Okay, it satisfies all of these criteria, and it is autogenous. It's fairly easy to prepare in dental setting. Okay, it is very rich in growth factors. It degrades over time and forms a three-dimensional fibrin matrix. Okay, the third important component is signaling molecules. So both growth factors and other compounds, they are capable of stimulating cellular proliferation and directing the cellular differentiation. Okay, the observed radiographic thickening of the dentinal walls might be due to production of cementum, bone, or dentin, any of these tissues. Okay, so it's likely that the cell source and the available signaling molecules, they play major roles in guiding the development of the cells in the regenerating tissue. Okay, then the dentin or the dentin extracts, rich in growth factors, they can perform formation of odontoblast phenotype. Ethylene diamine tetraacetic acid EDTA is also very effective material in releasing growth factors from human dentin. Okay, however, its effectiveness in promoting odontoblast differentiation and subsequently root development is yet to be evaluated. And regenerative endodontic has been proposed to replace damaged and underdeveloped tooth structures with normal pulp dentin tissue based on concept of tissue engineering by providing a natural extracellular matrix that mimics the environment which is required. Okay, the stem cells, signaling molecules, and scaffolds. Okay, so clinical success of the regenerative endodontics, it can be evidenced by absence of signs and symptoms of any kind of pathology or bony pathology, or disinfected pulp, and maturation of root dentin in length and thickness. Current endodontic regeneration is often referred to as revascularization, which disinfects the root canal using antibiotic mixture and irritating the root apex tissue to form a blood clot inside the root canal to act as a natural scaffold and to support pulp dentin stem cell proliferation and differentiation. Okay, a blood clot can function as a scaffold for ingrowth of new tissue since it consists of cross-linked fibrin, and this is the pathway for migration of cells, helps in growth and differentiation factors, and biodegradable scaffolds have been developed to deliver dental mesenchymal stem cells. However, recent studies, they report that regenerated tissues from the revascularization are mainly dentin-like structure or cementum-like or bone-like. Okay, composition of cells, signaling molecules, scaffolds are not contributing towards the pulp dentin regeneration. It's more of a repair. Okay, now let's look into these terms of revascularization or revitalization. The formation of blood vessels around the teeth, which provides the blood supply to the teeth, is called vascularization, which is important in tooth development and function. Therefore, the term revascularization was coined from a case report describing re-establishment of the blood supply in the teeth with incomplete root formation after autotransplantation or retransplantation. Successful regeneration is dependent on the rates of formation of new tissues versus bacterial growth. Okay, so this is one diagrammatic representation. Here, see, a blood clot is created after the canal is disinfected to act as a matrix for growth of new tissues. Okay, and Banks and Trope, they used a double seal with MTA and bonded resin to prevent any bacteria from invading the pulp space before revascularization would take place. Okay, so this is an immature tooth with necrotic pulp. We can see here it is an open apex. So what is done is stimulate bleeding by over instrumentation. So instrumentation is done up to the periapex to stimulate bleeding. So as a result, the blood, it flows into the canal to form the blood clot. Okay, and then we have to seal the tooth by placing a plug, okay, which is usually MTA, and a permanent coronal restoration. So this blood clot acts as a scaffold, okay, and later it is invaded by cells and growth factors, okay, and this leads to the regeneration of the pulp. Okay, this is the regenerated root formation takes place. Okay, so this is the procedure. So here the terms used are revitalization. We just understood what's revascularization. Revitalization is a term which describes endodontic procedure used to rejuvenate tooth vitality in cases of necrotic stages. Okay, regeneration has been defined as procedures of replacing lost or damaged pulp dentine tissue complexes. However, histological studies show that the tissue which is found in such root canals may not be, through the exact regeneration process, but instead through a healing process which is called repair. Okay, so the repair of the tissues has been used when the healed tissue inside the root canals, it recovers a similar form and elements of pulp tissue. Okay, now let's see this diagram. Here, see, it's explained that if we have an immature permanent tooth, okay, we check the vitality. If it's non-vital with necrotic pulp, then we do non-surgical root canal treatment with MTA apexification or root canal revascularization or endodontic regeneration. But if it is a vital tooth with some healthy pulp, then root canal apexogenesis is preferred. Okay, so what is non-surgical root canal MTA apexification? We disinfect the root canal with sodium hypochlorite, then instrument the root canal to remove all the necrotic pulp, then place a thin layer of MTA in the apex aspect of the canal with a moist cotton pellet for 1 week, and then remove the cotton pellet, obturate the root canal with gutta percha and sealer. Okay, seal the root canal with resin modified glass ionomer and restore the tooth with composite resin or later crown if required. Okay, so this is how non-surgical root canal MTA apexification is done. Okay, then now briefly summarizing the steps in root canal revascularization. Here, step 1 is disinfect the root canal, sodium hypochlorite, then apply antibiotic paste for at least 4 weeks, then stir the necrotic pulp to cause some bleeding in the root canal. Place a thin layer of MTA in the crown aspect of the canal with a moist cotton pellet for 1 week, and then remove the cotton pellet and seal the root canal access with resin modified glass ionomer. Okay, so this is how revascularization is supposed to take place. Okay, then endodontic regeneration and root canal apexogenesis. So endodontic regeneration, here disinfection of the root canal with sodium hypochlorite is done, then instrument the root canal to remove all the necrotic pulp, stir a file beyond the tooth apex to cause bleeding in the canal, then place a scaffold in the canal which can be plasma rich protein or Then place a thin layer of MTA in the crown aspect of the canal and seal the root canal with resin modified glass ionomer, and then restore the tooth with composite resin. This is endodontic regeneration, okay, regenerated pulp. Then root canal apexogenesis. Here cervical pulpotomy to remove only the inflamed pulp, only the diseased pulp tissue. Then root canal disinfection can be done with sodium hypochlorite, but only the inflamed portion is removed. Place a thin layer of MTA in the crown aspect of the canal with a moist cotton pellet for 1 week. Remove the cotton pellet and then seal the root canal or whatever portion which was removed, and then restore the tooth with composite resin. So we maintain the vitality of the tooth, that is root canal apexogenesis. Okay. Then crown restoration for immature teeth, the thin dentinal wall, it increases the incidence of root fractures in teeth after apexification. So restorative efforts have to be directed towards strengthening the immature root. Okay, a number of studies have demonstrated that the use of newer dentine bonding techniques can be significantly used to increase the fracture resistance of such teeth. Okay, Goldberg et al. They demonstrated that reinforcing effect of resin glass ionomer cement is quite good in restoring such immature roots. Okay. So, to conclude, endodontic management of pulpless permanent teeth with wide open apices has long been a challenge in dentistry. Okay, until recently, the most widely accepted technique was cleaning and filling the canal with calcium hydroxide to stimulate the formation of a calcific barrier or tissue at the apex, which is apexification. And a number of other treatment modalities have also been advocated. Apical barrier technique with MTA has now become the accepted treatment of choice. In non-vital open apex teeth with short root length, root can be completely filled with MTA. Okay. And intracanal medication with triple antibiotic paste consisting of equal parts of metronidazole, minocycline and ciprofloxacin for 4 weeks is another effective method. Okay. And other than that, the regenerative endodontic procedures are also gaining a lot of this thing in treatment or management of open apex teeth. The lot of research is going on these tissue engineering procedures. Okay. Now let's quickly see some of the questions. See, very basic questions are usually asked from this topic. Like this is one question: which of the following results in apexification? A. Pulpotomy of young permanent anterior teeth with incomplete root formation. B. Direct pulp capping of young permanent anterior tooth with incomplete root formation. C. Pulpectomy of young permanent anterior tooth with incomplete root formation. C. Apexification, we are always removing the entire pulp. Okay, so without any question the answer would be pulpectomy. That is a complete removal of the pulp from the young permanent anterior tooth with incomplete root formation. Okay, so that is the best possible answer over here. Then the second question I would like to discuss is, in an apexification procedure, any excess calcium hydroxide periapically, A. will cause necrosis in the periapical tissues, B. will resorb on its own, C. will be removed by multinucleated giant cells, or D. will have to be removed by apicectomy. C. Never ever jump to answer quickly, because the question, if you read it once, you might feel like you can answer, it will resolve on its own, because calcium hydroxide tends to disappear with time if it is pushed periapically. Okay, so some of you might if quick in a very in a hurry to answer, might go with the option of it will resolve on its own, but that's not correct. It is usually removed by the multinucleated giant cell, so that is more appropriate answer to this. Okay, then comes another question: after apexification, the root canals are best obturated by which technique? Okay, so out of all these techniques, obtura or thermoplasticized technique, that is thermoplasticized gutta-percha system, is the one which rapidly obturates most difficult root canals in very less time and very less patient discomfort. Okay, another question is CMCP, which is camphorated monochlorophenol Frank's technique, is used for apexification, is allowed to remain for it is allowed to remain for almost 6 months. Okay, camphorated monochlorophenol along with calcium hydroxide was a technique of epexification which was described by Frank. Here the material has to remain inside the root canal for 6 months. Okay, so these are some of the questions, and if there are any doubts, do let me know. Thank you so much for listening. All the very best.